Thank you, Rajlakshmi. Excuse me for not switching on the video. Not feeling well, so not unable to switch on the video. Thank you so much for joining us for today's session. Today we'll be talking about intervention pain management with specific focus on cancer pain management. We have, like previous sessions, we have two faculties for today's session. Um, we haven't met personally, Dr. Sanjay Sharma, but nice to meet you. Dr. Sanjay is from New Orleans. He's an anesthesiologist and pain physician, and he is also a clinical assistant professor in Department of Medicine. He's also a clinical assistant professor in anesthesiology. He has done his MBBS from JIPMER and residency and fellowship from US. Thank you so much, Dr. Sanjay, for agreeing to be part of this program. In the last, I think you didn't have much time to think and give the date. It was kind of a few weeks back we requested for session, and thank you so much for agreeing with such a short notice. We have Dr. Mayank also joining us. Mayank, Dr. Mayank is an intervention, sorry. So Dr. Mayank is a associate professor in the Department of Anesthesiology in AIMS, Bathinda. He has done his master's in palliative medicine from doing his master's in palliative medicine from Cardiff University, and he has done his MD in anesthesiology. So he has worked or ongoing work, a lot of work in pain management and interventional pain management. Thank you, Mayank, after so long, getting your time as a faculty for today's program. Welcome you both for today's session and welcome all the participants for a fruitful learning. So who will be going first today? Is it Dr. Sanjay or Dr. Mayank?
I'm okay with anything.
Yeah, me too. I mean, that's all right. I mean,
okay. No, I thought it's a continuation of one session. So probably, shall we start with Dr. Sanjay then?
Yeah, I'll go ahead and start. Thank you for the invite. This is the first time here. And nice to meet everyone. Good evening. And let me go ahead, share my screen with you. So, let's see which one. Just give me a second. I'm trying to open it up. Can you see my screen?
Yes, sir. Screen share should be good.
Okay, thank you very much. Okay, we can start. I hope you can hear me.
Yes, sir. We can see the second slide too. Is it okay with you?
This is the first.
The presenter mode that we are seeing.
Oh, okay. Sorry. Let me get out of this. Just give me a sec. I'm using our hospital computer, so I'm a little bit not very familiar. So
maybe you can stop sharing your screen. Just open the PowerPoint and just share only the PowerPoint. You have shared the entire screen. Maybe that's why we're able to see the presenter view.
Okay, let me just give me a second.
Yes.
Good.
And apologies, I will not be opening my camera as the internet signal is not very great here. Yeah, so before I thank you, Shri, and thank you, Pallium, for once again giving me this opportunity to present on this platform. So without further ado, and before I progress to my presentation, may I know that how many anesthesiologists are there among the participants? You can raise your hands on the by using the icon. You can help me there, Shri, to get an idea how many are there.
I can see 3 hands right now.
Okay. And has anyone done any interventions, interventional pain management procedures ever? Okay. 2, 2, 2. Okay. And was it for cancer pain or chronic pain? Non-cancer pain? Okay.
Both, sir, both.
Okay, both. So, yeah. So this is the brief overview of my presentation. I'll be discussing why interventional pain management is important in management of cancer pain, or where does the intervention stand within the whole spectrum of care that we give for cancer pain. What are these interventions? Which interventions to select for which patient? Yeah. So why it's important, or why interventions are important, or interventional pain management is important in management of cancer pain? Because if you look at the magnitude of cancer pain, it's exorbitant, and it's not just cancer, but almost all chronic life-limiting illnesses. The prevalence of cancer has been found to be tune of 70 to 90%. So considering the magnitude of the cancer pain and its impact on the life of the people, the WHO gave its WHO analgesic ladder, which is now considered the standard of care for management of cancer pain. I'm sure the WHO analgesic ladder must have been discussed by now. So it consists of 3 steps. Step 1 is for mild pain, that is NRS of 1 to 3. Step 2 is moderate pain, where you give weak opioids plus minus adjuvants, which is for moderate pain, NRS of 4 to 6, and the severe pain, in which you give strong opioids plus minus adjuvants, which is for severe pain, that is anywhere NRS of 7 to 10. Although no randomized controlled trials have been conducted so far, which have evaluated the efficacy of WHO analgesic ladder for management of cancer pain, and there is no this is because it would be very unethical to give analgesics to one group and no analgesics to another group. However, all the retrospective studies and the observational studies have found good to satisfactory analgesia in vast majority of the cases. So these are the 3 systematic reviews which have seen the efficacy of WHO analgesic ladder in the management of cancer pain. They also acknowledge that the ladder is able to effectively manage pain in majority of the patients. However, there is a subset of patients, that is 10 to 20% of cancer patients, who do not respond to WHO analgesic ladder. If you look that why WHO analgesic ladder might not be working in some patients, or why the cancer pain is difficult to manage with the conventional analgesics, it may be because the patient's disease has progressed, or there is loss of, the patient has developed tolerance to the analgesics which you are giving, or there are intolerable side effects because of which patient is not able to take tablet morphine, or there is a condition known as opioid-induced hyperalgesia. If a patient has neuropathic pain, and if you keep on increasing the doses of the opioids, the patient start developing pain in other areas of the body, what we call as opioid-induced hyperalgesia. Or the patient may have multi-organ failure, because of which you are not able to increase the doses of your opioids. And so these are some of the some etiologies of cancer pain are not very responsive to the WHO analgesic ladder, for example, or to the analgesics. One is the bone pain, then is the neuropathic pain, or the breakthrough pain. I'll explain why breakthrough pain is very tricky when we come to titrating opioids for management of breakthrough pain. So what is breakthrough pain? That the background pain is patient gets intermittent spikes of pain, which are severe in intensity and short lasting. So these are the salient features of breakthrough pain. So what happens if you keep on increasing the doses of opioids? So the patient will have the, hello, am I audible?
Yes, sir, you're audible.
Yes, you're audible.
Yeah. So if the patient has very frequent breakthrough pains, and you keep on increasing the doses of opioids, then that lead to the increase in plasma concentration of the opioids, and the patient will develop intolerable side effects. Patient will become drowsy, which most of the patients, they do not like. So this is what I explained, that if you keep on increasing the doses of opioids, they do not act only on the breakthrough pain, but the patient will have these increase in doses, plasma concentration of opioids in between these breakthrough pains, which will, and the patient may develop side effect if the breakthrough pains are very frequent in nature. The second condition is neuropathic pain. There are a number of neuropathic pain syndromes, for example, chemotherapy-induced neuropathic pain or the compression due to tumor. Etiologies are varied. I'll not go into the detail. So neuropathic pain is again one pain condition in which are not very responsive to opioids. The etiology of neuropathic pain in cancer may be, it may be either the sympathetically mediated pain, or it may be the nerve compression or the nerve injuries due to chemotherapy, due to radiotherapy. So a number of studies have shown that these patients have poor outcomes with the WHO analgesic ladder to the tune of 40 to 50%. It's difficult to manage their pain with WHO analgesic ladder because the pathophysiological mechanisms behind the neuropathic pain, they are not very amenable to the treatment with opioids. So this is the neuropathy. Some sort of changes occurs within the nervous system. Wind-up phenomena occurs, which leads to central and peripheral sensitization, which leads to neuropathic pain. So, sorry, there is some problem with my system. Yeah. And the tricky part is that the most common tools, for example, the pain detect and the SLANs, which are routinely used for the assessment of neuropathic pain, they are not able, they have been found not to be very effective in recognizing moderate to severe neuropathic cancer pain. They are okay when it comes to the mild pain, but they are not very sensitive or specific when it comes to the assessment of moderate to severe neuropathic cancer pain. A number of guidelines are available for the management of non-cancer neuropathic pain, but in cancer pain, it's usually a mixed etiology. That is, the patient have mixed nociceptive and neuropathic pain. So considering them, a number of pragmatic approaches have been, both the WHO ladder as well as the neuropathic pain ladder have been modified to have a combination of both of them. But despite these, some patients, they do not respond to the conventional analgesics. So how to manage when the WHO analgesic ladder or the conventional analgesics are not very effective in management of pain, and the patient is not, or the disease is not amenable to the disease modifying treatment. So far till these patients used to suffer in pain, and there was the doses of opioids used to be increased. The patients keep on having intolerable side effects. So, and this in unrelieved pain has effect on every aspect of patient's life. It has been shown to reduce the performance status of the patient, leads to psychological morbidity, leads to anger, depression, and so interventional pain management provides a useful bridge when the conventional analgesics are either not effective or patient is having intolerable side effects and the disease is not amenable to the disease modifying treatments. These interventions not only reduce pain, they have been found to improve the quality of life. And in some cases, for example, celiac plexus block has been found to have survival advantage as well. They are particularly effective in breakthrough pain. So for example, if I talk about oropharyngeal cancer pain and patient has frequent odynophagia, you imagine you keep on increasing the doses of opioids, but the patient will have intolerable side effects because of those opioids. But if you give a pulse radiofrequency of the glossopharyngeal nerve, that is very effective in management of breakthrough pain due to oropharyngeal cancers. So considering all these advantages, a number of modifications have been proposed for the WHO analgesic ladder, in which the interventions have been proposed at 4th step. But nowadays, there is a concept of early interventions. For example, in patients with CA pancreas, which is amenable to celiac plexus block or a splanchnic nerve block, a number of studies are coming up which has shown the celiac or the splanchnic nerve block not only to reduce pain, but also have to reduce opioid doses, opioid-related side effect, and an improved quality of life of the patient, which I'll be discussing. So these interventions are aimed at maximizing the pain control, improving the quality of life, and minimizing the side effects, treatment burden, and complications of treatment of pain. So considering all this, even the NICE has recommended that each cancer network or each cancer center should have a pain management specialist who has expertise in nerve blocks and neuromodulation techniques. So now coming after all this background that why interventions are important, what are interventions or what is the interventional pain management? It is the branch of medicine or a discipline of medicine that deals with diagnosis and treatment of pain by using certain minimally invasive interventions. So we can classify them on the basis of mechanism of action. It may be either targeted delivery of drugs, or it may be the ablation of nerves, we call it neuroablative procedure, or it may be modulation, we call it as neuromodulation. They may be classified on the basis of intention, whether it is to diagnose a particular pain condition or what is the pain generator, we call it as a diagnostic block, or it may be therapeutic block, that is we are giving either local anesthetics, we are giving either alcohol, phenol, or we are doing radiofrequency ablation. They may be classified on the basis of the which part of the nervous system they are targeting, whether it is the somatic or the sympathetic nervous system. And the modality I have already discussed, whether it's a targeted delivery of drugs or a neuroablative or a neuromodulation procedure. So a number of interventions are available for cancer pain due to almost all parts of the body. There are certain intervention if the patient has head and neck cancer pain, or a thorax or upper limb, or an abdominal or a lower limb pain. So what are the interventions that have been found or that are available and have been found to be effective for management of head and neck cancer pain? So suppose a patient has a CP angle tumor or any other cancer of the head and neck, which is leading to pain in the trigeminal distribution. So you can either go for a trigeminal RF, or you can go for a maxillary and mandibular approach. So you can either go for maxillary or mandibular, or you could transcoronoid approach, or you can directly approach the foramen ovale and approach the Gasserian ganglion. So this was a study from the Mayo Clinic. It was a large retrospective study of 5,000 patients in which they found that out of all trigeminal neuralgia was present in about half of the patients who presented with intractable facial pain. And the tumors were the etiology in 10% of these patients. And there was a delay of approximately 6 years in the diagnosis of tumor diagnosis after the trigeminal neuralgia presentation. So it's not very uncommon. Not only foramen ovale, we can go for maxillary and or mandibular nerve block or radiofrequency ablations. If the patient has pain in particular in distribution of a particular nerve, for example, so we can go for a supraorbital, infraorbital, or a mental nerve block. What I have found very effective in patients with head and neck cancer and low resource setting is a sphenopalatine ganglion block. So sphenopalatine ganglion is the largest ganglion outside the cranium. It has sensory, it has motor, it has sympathetic and parasympathetic, and it is effective for a lot of pain conditions of head and neck. Why? Because all the efferents from the face, they are traversing through the sphenopalatine ganglion and then going to the trigeminal ganglion. So it provides an easy target as well as easy to do block by a novice anesthesiologist or someone who is trying to start with the interventions. So there are many approaches to sphenopalatine ganglion block, which I'll discuss. Another block which has been found to be effective is glossopharyngeal nerve block. A patient who has oropharyngeal cancer pain, they have severe breakthrough pains, they have odynophagia, and if you keep on increasing the doses of opioids, patient may develop side effect. So we can do a glossopharyngeal nerve pulsed RF for these patients. And it has been found to not only reduce pain and odynophagia, but has been found to reduce the side effects of medications, for example, nausea, and it has been found to improve the sleep and the mood in patients. So this is what I was talking about. We in our palliative care OPD, we do a lot of sphenopalatine ganglion transnasal blocks, and we teach them to the relatives who we think will be able to do that, so that the patient can do a transnasal sphenopalatine ganglion block. And believe me, patient gets excellent pain relief. Head and neck cancer patients get excellent pain relief with transnasal sphenopalatine ganglion block. And in certain conditions, most of the times, we do not go for a therapeutic or a transcoronoid approach. The patient keeps on doing transnasal sphenopalatine ganglion block, and one block, the patient has effect for some time. The opioid doses, they do come down. and the breakthrough pain also reduces. Now coming on to the intractable thoracic or chest wall pain, for example, patients with CA lung or who have metastasis to the chest wall, and they get intractable pain along the intercostal nerves. As the moment the patient breathes, the patient gets a severe neuralgic pain along the intercostal nerve distribution. You can go for intercostal nerve block. You can do it blind. You can go do it ultrasound guided. You can do it fluoroscopic guided. The disadvantages, you might have to do 2 or 3 intercostal nerve blocks, and there is always a risk of pneumothorax. We, as anesthesiologists, we all are aware of paravertebral block, which is coming into now management of cancer pain as well. We can go for a thoracic epidural and we can put in a catheter, but these interventions are not very frequent for management of cancer pain. Again, for now coming on to the interventions for which there is maximum evidence and which are most effective for management of cancer pain are your sympathetic plexus block for abdominal and pelvic cancer, and the highest level of evidence is for celiac plexus neurolysis for patients with upper abdominal malignancies. We all know we can approach celiac plexus block. There are a number of approaches available, and I don't think that this half an hour or 20 minutes lecture or so, the technique of celiac plexus block comes under the purview of it. But as I told you that we have published our Indian guidelines that what is the evidence for interventional pain management in cancer pain, and the highest level of evidence is for celiac plexus block. So this was a 2011 Cochrane review, and I don't think so it has been updated so far. So it showed that although if we compare the pain score, the effect was not very clinically significant, but the thing that it reduced the opioids and the opioid related side effect was very much important for the patient, and the patient preferred to have celiac plexus block. So again, this was an update of Indian guidelines, which was published in 2020, which was in combination with ISSP and IAPC. And the highest level of evidence was found for neurolytic celiac plexus block for management of upper abdominal malignancies. A number of recent systematic reviews have shown that celiac plexus block reduces the pain. It reduces pain. It leads to reduction in the doses of opioid-related side effect, and even some of them have shown survival advantage. Most of the complications are transient, but beware that if you are doing it ultrasound guided or if you are doing it blind, which we do not recommend nowadays, there is always a chance that you might inject your alcohol within the artery of Adamkiewicz, and the patient may develop paraplegia due to it. Another thing to keep in mind is because it leads to sympathetic blockade and vasodilatation, patient may have hypertension. So always preload your patients before giving for celiac plexus block. This is what I told you, that it has been not found to not only reduce pain, but has been found to improve mood and has found to have survival advantage in patients with unresectable pancreatic cancers. When it comes to the pelvic malignancies, the intervention which has the highest level of evidence is superior hypogastric plexus block. So there are again 2 approaches. The transdiscal is which most of the pain physicians are more comfortable at. You can do it ultrasound guided, you can do it fluoroscopic guided. For perianal and anal pain in the anal region or perianal region, we can go for ganglion empire block. So ganglion empire is the last ganglion in the sympathetic chain. You can go through the sacrococcygeal junction, again fluoroscopic guided, and you see the scoma shaped image of your contrast, and you inject your local anesthetic or alcohol at this place. Then comes to the intrathecal drug delivery system, which I do not have any practical experience about. The reason being, most of our patients are very poor. They come very late in the disease process. And frankly speaking, I have never done an intrathecal drug delivery in any of the patients. I would be more than interested in hearing from the other part of the world about the experiences with intrathecal drug delivery system for management of cancer pain. But just to give an overview, it provides highly selective pain relief from sinus. It leads to drastic reduction in the doses of opioids. So it leads to almost at least 1/300 is the concentration if you take it orally or if you give it intrathecally. That's the reduction in the dose of morphine which you can achieve with the intrathecal drug delivery system. These are the drugs which are given. Morphine and ziconotide are the only drugs which have been FDA approval, but off-label use of other drugs is common practice. So I don't think so. I'll go into details of intrathecal drug delivery system because I do not have any practical experience, and I do not see much indications of intrathecal drug delivery systems within Indian context where the population is poor and they come late in the disease process. So this is the number of trials which have it shown to be effective. Another thing, another procedure which is like patients who have pathological fractures of the vertebrae and they have severe back pain, we can go for vertebroplasty and kyphoplasty. Balloon kyphoplasty is more effective, has been found shown to be more effective than vertebroplasty in relieving the pain. And it can be done at multiple levels for this. And then as the neurodestructive procedures, again, I do not have any experience with the neurodestructive procedures. I think so UK is the country where they are done in maximum So this is what the traditional model was, that the patient used to have maximum, have the opioids were, or these conventional analgesics were tried to the maximum and the patient was intractable. They were referred to the interventions, and very late in the disease process, when they are not even amenable to the interventions. For example, if I take the example of CA pancreas, it has already involved the celiac plexus. When the celiac plexus block will not be effective. So now we are shifting away from this traditional model to the salvage model. This is because there is a significant proportion of patients who have very severe breakthrough pains, in which, or patients have pathological fracture pains, in which the WHO, we know that the WHO analgesic ladder is not very effective, and there are interventions which have been found to be effective for such pains. This is it. So a lot of studies are coming for which are showing the efficacy of early interventions in managing pain, improving the quality of life of the patient, and the maximum evidences for celiac plexus neurolysis for patients with cancer pain. I think so I'm done with my presentation. This is the evidence which is there. Thank you so much.
Thank you so much, Dr. Mayank. I guess we can take the questions in the end after Dr. Sanjay's presentation also, so that you both can pick up the questions if there are any. If that is okay. Yeah. Over to you, Dr. Sanjay.
Oh, thank you, Dr. Sridevi. Let me try again to share my screen. This is a different computer, so I'm not used to. So let me try again. If I'm not successful, then I'll ask Ms. Rajalakshmi. So sure, let's see. No, I think I'll ask Ms. Rajalakshmi, if do you mind sharing the screen? I'm sorry. Okay, thank you very much. So thank you, Dr. Mayank, for your very lovely presentation. So I had already seen it before. So I decided to shift more to the general overview of interventional pain. So I think I'm going to take it from there. And next slide. So this one, chronic pain is very, very complex situation where there are so many pathways and the basic science. I won't go too much into the basic sciences of it, but this is just to get it started, how complex it could be, and with all those pathways and different sensitization, central, peripheral. So moving on to the next slide. So there are various a lot of modalities. Managing chronic pain is pharmacological, interventional, rehab, psychological, complementary and alternative medicine, lifestyle changes, and spiritual. And, and chronic pain has occupies a large part in palliative care and chronic pain management. And these are the different ways we can manage them. And even managing chronic pain, interventional pain management plays a very, very major part in that. Next slide. And the strategies that we adopt are address chronic pain issues, address psychological and other mental health issues associated with the chronic pain, improve functionality, that is very important to improve the quality of life, and other comorbidities that might be possibly affecting their pain. Next, please. Now, at our work in the VA here in New Orleans, we have a certain workflow for our chronic pain patients. So what happens, first of all, obviously they are seen by the primary care providers, physicians, and also the specialists. So they put in a consult for the pain management, and they come to us in the pain medicine department, or it goes directly to another section which is called the pain evaluation program, which is comprised of primary care physicians, pharmacists, pain specialists, and psychologists. So this is mostly for medication management. So yeah, so, and then of course they can always, they're welcome to consult us, but this section of pain management is run by the primary care section. Now here, another place that they can directly refer to us is the interdisciplinary pain clinic, which is actually staffed by pain specialists, mental health specialists, psychologists, and psychiatrists, and physical therapists. So there again, that is very similar to pain evaluation program, except for that we do not have primary care here. It's solely pain management, the pain medicine providers. And then the next thing is, which is a very major section of our service here, is the interventional pain clinic. So anybody can consult the interventional pain clinic, and it is run by pain specialists. We have nurses, we have fellows and residents here. So we evaluate the patient and see what all intervention we can do for them, and then we go from them. And from time to time, we also consult the interdisciplinary pain clinic or the pain evaluation program for to help us with the medication management. So what we do here in the interventional pain clinic, actually I'm sitting in one of the suites here, interventional pain suites, and we're doing procedures every day. So, okay, going to the next slide, please. And the types of chronic pain patients typically seen here are chronic back pain and neck pain, which forms a very huge back pain, and neck pain is actually major area, as Dr. Gupta had said, section of the pain or pain patient population. Then arthritic pain, neuropathic pain, complex regional pain syndrome, visceral pain, cancer pain, and post-surgical pain. So to sum it, this is there might be other kind of pain, but I'm just kind of outlining a few of them, and each one of them is a lecture by in itself. So we go on to the next slide. Next slide, please. Okay, so I'm going to start with back pain. And for back pain, we have to get an image, get the imaging. We need an MRI or a CT scan for every patient who comes with back or neck pain. Next slide. Now, among the back pain, we have different kinds of pain: spondylosis, facetogenic pain, radicular pain, and the most difficult part of the most difficult to manage among the back pain is the discogenic pain. It's the hardest to manage. So I'm going to spend a little bit time talking about the discogenic pain. Next, please. Next slide. As you know, the intervertebral discs are very, very tough organs. They're very nicely designed. It is comprised of the annulus fibrosus and the nucleus pulposus, and it is a very tough structure, and it can actually sustain pressure of maybe even more than 300 psi's. So, but what happens physiologically? It's a very, I would say, very finicky kind of organ. Anything that disturbs the internal environment just sets up a cascade of degradation and everything. And just to go through this briefly, though, this chart here, overuse, obesity, trauma can cause changes in free radical production, nitric oxide, hyperosmolarity, and then there's dysregulation, inflammation, pro-inflammatory cytokines, and all this. I'm not going to go too much detail, but what eventually happens is pain, inflammation of the disc itself, and also in the adjacent vertebral bodies, as you will see in an MRI in a few seconds. So, and then there is, of course, sensitization, peripheral and central, and it becomes very hard to manage these patients because this discogenic pain can lead to other kinds of pain in the back. So next, please. Okay, here is the MRI, T type 1, and type 1, you see here, this is the initial part of discogenic pain. If you see the arrows, the left side, the top left. So that is the T1 weighted image, where the fluid appears dark, and the one just next to it is the T2 weighted, where fluid appears light in color. So that signifies inflammation in the bodies. And look just below that on the left side, you will see that as the inflammation goes on, it's replaced by fat. Fat appears both light in color in T1 and T2 weighted images. And subsequently, subchondral sclerosis, then everything appears dark. I don't have that MRI here. On the right, you see here again, the top two discs are nice and plump, and they look whitish because they have their water content. Then the lower one is desiccated and darkish in color, and the arrow is showing the hyperintense zone, which is annular fissure. So these are the things that can set off these changes in the MRI. So imaging is very important, like I said before. Next slide, please. Now here, what are the things, the sources of pain from a degenerative disc? So secondary changes. So disc herniation, of course, it's a mechanical thing. It herniates and pushes on to the neural structures, the nerve roots, the cauda equina, or in the neck of the nerve roots, of course, and causes irritation of the nerves, causing radicular pain. And what happens when there is disc desiccation, narrowing of the disc, the vertebral bodies come close together, which kind of closes the intervertebral foramen, causing foraminal stenosis, irritation of the nerves, or even just destroying, damaging the nerves. And then also what happens, the disc bears most of the weight. And then once the disc starts to degenerate and most of the weight shifts over to the facet joints, which is present posteriorly, and then the facet joints start having the arthritis, and they start getting dysfunctional. So then that can lead to facetogenic pain. And then again, another thing that it can do, another thing it can do is brings the lamina in the back. I'm sorry, I don't have a model of the thing. So lamina in the back come closer together. The ligament of flavum, which is present, becomes loose and buckled, and that pushes into the central canal and causes central stenosis of the spinal cord. Central stenosis of the canal, and that can, of course, you have symptoms of spinal stenosis, neurogenic claudication. When the patient walks a little bit, he or she starts having pain in the back, or which might go down into the leg, and also the forward. You will notice as soon as the patient walks into your office, he's kind of leaning forwards. So forward leaning can actually relieve some of the pressure which is caused by the spinal stenosis. So here again in this diagram, the different locations of this herniation, central, then lateral recess, subarticular, and then the foraminal, and then there is extraforaminal. Sometimes the disc material can get extruded and go into the foramen. Thank you. Next slide, please. And of course, coming to neuropathies. So neuropathy is kind of, it is actually overlaps with other conditions also, like spinal conditions. But then we have the ones that we commonly see are complex regional pain syndrome, which is as seen as like hyperalgesia and pain, doesn't form any dermatomal pattern. And then, of course, post-herpetic neuralgia, diabetic neuropathy, trigeminal neuralgia, occipital neuralgia, cancer pain. Of course, Dr. Mayank had touched on it a lot. And post-surgical pain after inguinal hernia, mastectomy, thoracotomy, which we see a lot here as well. So these are the things that can also be treated. Next, please. Okay, so coming to the actual procedures and everything with the interventional pain. Next slide. Common interventional pain procedures are spinal injections, joint injections, nerve blocks, sympathetic nerve blocks, neuroablative procedures, neuromodulation, which is the spinal cord stimulator, and intrathecal drug delivery systems. Mostly we use that for for cancer pain and kyphoplasty. So each one of them has actually is a lecture on its own. So I'm just going to just briefly mention them as we go along. And next, please. And then, of course, we have the newer type of procedures available, which are the regenerative procedures, peripheral nerve stimulators, vertiflex, intercept procedures, and mild procedure. So I'm going to talk about it as we go along. Next slide. So regenerative medicine, basically the concept is to use plasma cells. So we use platelet-rich plasma, which can be injected into the joint, back, or the joints, other joints, knees, and it is not very. Some people, the people who practice it, claim that it's really helped, and there's no real study that shows that's very helpful, but it does help some patients. So people have started using it here a lot. And so mesenchymal cells and bone marrow aspirate, chondrocyte transplants, and annular closure devices and nuclear pulposus replacements. So next, please. And of course, this is disc biacuplasty, which is we're using radio frequency. It's basically cool radio frequency. Traditional radio frequency goes up to 80 degrees Celsius. This goes up to 55 to 60 degrees. And as you see here, the posterior part of the disc is the innervated part of the disc. That's the most painful. So this is used for discogenic pain. So the two electrodes are placed, and it's a bipolar kind of setup, and lesions cause creates a lesion in that area. And it's about 2.5 to 3 minutes at a temperature of 55 to 60 degrees. So it's supposed to help a lot of patients. The patient wears a back brace for about 6 weeks after this. And I'm not so much in a favor for this, because I had mentioned earlier that anything that disturbs this structure, you further go down, like you're making 2 holes in the annulus, and that can cause a lot of that. At that point, for a few years, maybe a year or two, patient will get a lot of relief. But further down, because you have disturbed the structure of the disc, all the downward cascade will start in the disc, and it will get from bad to worse. So but it is being used. I just put it there because people use it, and it's being used quite frequently. Here, next slide. Then, of course, this is just the X-ray image of that, how we place the electrodes there. And the tip of the electrode doesn't go into the annulus, into the nucleus, it just goes into the annulus. And that's how this, on the left, it is the AP view, and on the right is the lateral. So we check both X-rays before we place them. And the name of the company is Coolleaf. And next slide. Then again, this is another very useful procedure, intraosseous basivertebral nerve ablation. We use that for discogenic pain. The inflammatory mediators from the disc, as I had shown earlier, go into the bodies, and then there is cause inflammation in the body as well. And the nerve that goes, the main nerve that goes to the disc that carries sensation, is a intraosseous basivertebral nerve. So we go in and ablate the nerves. I'll show you in a second. Next slide, please. This can be done under mild sedation. An introducer, it goes through the pedicle, as you can see here, into the body of the disc, and a probe is cannula goes all the way to the center of the body of the disc, and then they use radio frequency to ablate the nerve in that area, and supposed to help discogenic pain for a long time. Mainly used for people who are not candidates for surgery, or who don't want surgery, or too young for surgery. So this can be helpful. Okay, next, please. And this, of course, the study that's shows the efficacy of this, and seems to have good outcomes. People have started using it here for some years now. Okay, next slide. And of course, this is a peripheral nerve stimulator. It's very easy to use, and the same concept as the spinal cord stimulator. This stays outside the body, and there are 2 probes, as you see here. Very thin leads that sits onto the medial branch, mostly for back cystogenic pain. We find the center area of pain. We place the leads there and put a dressing, and the stimulator stays outside, and it can stay there for 2 months, and then after 2 months we can take it out. It's supposed to help anywhere between 1 to 2 years, and it can be for any peripheral nerve, the back, neck, the neck, greater and lesser occipital nerves. So that's something we can try. So these are the newer things that we use. And next, please, next slide. And then, of course, we have the Vertiflex, which is a device which is placed percutaneously between the spinous processes from the back, as you see here in this picture. And what it does is causes a little bit of a forward flexion of the spine, and opens it up. So it's very useful in spinal stenosis patients. And it is much quicker and less invasive than laminectomy and back surgery. So we, we can do 1 or 2 levels. Only thing we have seen that the lower levels actually show better results in the higher levels. And we try this for patients who are not candidates for surgery. And next slide. And of course, a little bit about the complication. Anytime you do anything to a patient, there are complications, bleeding, which is especially in patients who are on anticoagulants. Very important to make sure what anticoagulants they are on. And actually, there is an app by ASRA, American Society of Regional Anesthesia and Pain, that it's not very expensive. It's very cheap. I think you can download it on the phone and you can check all the anticoagulants, like cardiac and others. That, and also you can check on that and see which procedure it is useful. So it's a useful thing to have on your phone. So you might already be familiar with that. So, and then of course nerve injury. Nerve injury is very important. It happens a lot with these procedures. Spinal cord injury, another thing for higher up neck, infection, local anesthetic toxicity where we're doing regional anesthesia. Acute pain management, we inject a large volume of local anesthetic. That is another thing. Vascular injury, again, when we do these procedures. Pneumothorax. So that's possible. Even with simple things like trigger point injections, we can get pneumothorax. And post-dural puncture headache for epidurals. So these are some of them, some of the complications. I'm going to elaborate a little bit further. Next slide. Spinal cord injury. Next slide, please. Okay, so this is just a diagram of interlaminar ESI at the thoracic level. So you see in A and B is right interlaminar. It's coming from the midline or the paramedian. This goes into the posterior part of the epidural space, and the two on the right, C and D, are the transforaminal epidural steroid injection. We can access the epidural space to the foramen. Some people go straight in a straight view and with the needle, but there's a risk of causing the nerve root or dorsal root ganglion injury from this technique. The other technique is to go in from an oblique direction, where there's again some risk of injuring the vascular supply, as you can see here, the spinal branch. And a bit of the, so there are some ways. I'm not going to elaborate too much how you can avoid that technique wise, and that'll be more for pain people who are doing pain management. Next slide, please. Here again, a different picture. The lumbar interlaminar epidural, as you see, the needles coming from the top. The epidural space there in the lumbar area is about 5 to 6 millimeters. And it's a fairly safe procedure, and then we do it a lot. And when we do spinal cord stimulators, we place the stimulator leads in the epidural space. And in anesthesiology, we use it a lot perioperatively in the OB, and also for chronic pain. So next slide, please. Now again, cervical interlaminar is epidural steroid injections. Here again, there is a little bit of a risk here. We have to make sure the patient is off all anticoagulants, and the epidural space is very small, about anywhere between 1 to 3 millimeters in the cervical spine area. And even a slight thing, there's a very high risk of injuring the spinal cord here. So has to be done very carefully. Of course, we do everything under fluoroscopic guidance. So I thought I'll mention some of these things as complications because we're talking about interventional pain. So all of you might not end up doing this, but I thought I'll just bring it out. So next slide, please. Now, transforaminal injections in the neck, which we are moving away from doing that. Some people still do it. And there are very, the spinal segmental arteries are there, branches from the vertebral artery pass through the foramen. And if there is an injury to the, either just a transection of the artery or just causing the spasm, it can cause a lot of ischemia to the spinal cord in that area. So it's very high risk. And a lot of people are shying away from doing this now. So next, please, next slide. And of course, lumbar transforaminal, we already talked about it a few minutes ago. Next slide, please. As you can see here, this is the MRI of view of the intervertebral foramen, and the arrow is pointing to the artery, cross section of the artery. And the one on the side of it, the bigger grayer, those are the nerve roots. So just to give you an idea that it's so easy to go close to it and injure it. Especially the upper lumbar or lower thoracic area, we have the articularis magna, which can be injured easily, and it supplies a major portion of the spinal cord. Next slide, please. Here again, arterial supply to spinal cord. So from the aorta, you have the segmental arteries and the spinal branches and radicular artery, also called the articularis Adam Creeks or articularis magna. So there is one anterior spinal artery and two posterior spinal arteries, but the majority of the blood supplies from the anterior spinal artery. Next slide, please. So here again, same risk in the celiac plexus block. We do a lot of those for abdominal cancer pain, pancreatic cancer pain. Here again, there's a risk of damaging the artery, causing spasm. Next, please. Okay, I'll just go through a case report. Finish in a couple of minutes, sorry. So this patient, you see the MRI, there is, on the left side, you see a bulging disc into the space there, lumbar area. And on the right side, the B part, you can easily see the bulging disc. And it was decided, this was from one of the interventional radiology. Next slide, please. So they did the interlaminar epidural steroid injection, and here there is, you can see here, the contrast is accumulating in this image. This is the digital subtraction image. We do that to make sure there's no vascular uptake. So next slide. So what happened after that? The patient started having a lot of back pain and started having weakness in the leg, and went to the ER. They did a CT scan. It showed this collection of contrast still there after a few hours, and so they went ahead and did an MRI. Next slide, please. So here MRI, that bulge that we saw in the earlier MRI, it's so big now, and it was actually an extruded fragment from the disc, and into which the needle went and caused this and caused so much symptoms. Immediately the patient was taken for surgery. Next slide. And they removed part of the disc material. Patient recovered well after this. So this is a rare thing, but we have to be very cognizant of all these complications that we see when we do these procedures. So I think that I'm coming almost close to finish. Thank you very much, and we can go on to the next one.
Thank you so much, Sanjay. We can wait for a few minutes for if there are any questions. And then we have one case presentation for today from the participant side. So we'll wait for 1 or 2 minutes. Participants, if you have any questions, kindly unmute or type it in the chat. Yes, Dr. Prakar.
Yeah, hello, ma'am. Ma'am, Dr. Mayank said that nowadays the trend is to go for early intervention in this chronic cancer pain patients. So my question was, how early are we going in? So for the pain relief, and number two is for that nerve block, celiac plexus block, and all. Are we using neurolysis or are we giving steroid injection only over there?
Yeah. So thank you for your question. So I'll take the second question first. We do not give steroids for the celiac plexus block. Sometimes if we are doing ultrasound guided, we go for a diagnostic block to see whether the patient is getting pain relief and how much pain relief it is. And if the patient gets an good pain relief, we go for the alcohol neurolysis the same day or maybe the next day if we are doing an ultrasound guided celiac plexus block. Your first question was pertaining to how early is early. So there are no as such guidelines which I'm aware of that how early is an early. But the thing is that no point in giving for a late celiac plexus block when the tumor has already involved the celiac plexus and we know that it's not going to be effective at that point of time. So what I can tell you what my practice is, if the patient comes with the CA pancreas, particularly I'm talking in terms of CA pancreas for an early intervention. If the patient comes with CA pancreas, if the patient has mild to moderate pain, we start with our analgesics. But if the patient does not respond that good in the second or the third pain clinic visit, we start evaluating the patient. We start explaining about the celiac plexus block and see that how does it go. So it's about you discuss the pros and cons of celiac plexus versus conventional analgesics with the patient and let the patient decide. It's not that we are very pro interventions, but yes, in celiac, especially with CA pancreas, I'm much in favor of celiac plexus block.
Dr. Mayank, just humor me for a minute. Today I had a patient, CA pancreas. Okay, so he was on 2-3 analgesics before that, but at another hospital he was given a very early celiac plexus block with a neolysis was given. And unfortunately for him, this was in October. That procedure did not work, and he continues to have pain till now. And he is on high dose morphine. He has lost a lot of weight, but because he has already undergone that procedure, he is not now ready for any intervention. He is saying it doesn't work on me.
Yeah, so that's the problem when we say, because a lot of people they give blind celiac plexus block. Even now, I know some people they go for blind celiac plexus even now. So you do not know that how the celiac plexus was given and how was the dye coverage around the celiac plexus. So and you may I know how much analgesics the patient is on as of now? You said high dose morphine. How much it is?
Yeah, he is having a fentanyl patch. He is having 200 mics per hour patch he is applied, but is still having a lot of breakthrough pain with that. And paracetamol 1 gram twice a day.
So if this patient was with me and I was evaluating him, I would have given him the option of a diagnostic celiac plexus block, ultrasound guided celiac plexus block in my maybe with as a 1-day admission. I don't do a celiac plexus as a daycare admission because of the hypertension and other things which may occur with it and the diarrhea which may occur with it. So a diagnostic block and let the patient see that how much pain relief the patient is getting with the local anesthetic. If it does work for him, I'm sure that the patient will say that yes, they would go for the therapeutic block. Otherwise, if this patient still does not want for a diagnostic block, you can think of rotating the fentanyl patch to maybe morphine again and see how much the patient responds to it.
Yes, sir.
Any other questions from others, or I think we can move on to a case presentation because otherwise we may not get time to finish the discussion. Or is there any question? Dr. Shweta, you have anything to ask?
Ma'am, I just wanted to know
Yeah.
that for how long we can use patches in cases of like carcinomas, because there the patient is on analgesics for very long time. So is there any time period for which we can use fentanyl patches or buprogesic patches before we think of interventions?
Anyone of you want to take up the question? Any of the faculty?
Okay, to answer your question, I think there is no time frame for opioids or fentanyl patches for cancer patients. We can continue as long as it's helping the patients. Intervention can be used. It's not either this or that. We can use both. We can continue with the opioids along with the intervention if it's deemed that that's going to help as well.
Sir, specifically if there is a CA pancreas case and we know that the longevity will not be more than 6-7 months if it is metastatic, then even then should we try for intervention or just manage on other modalities?
Yeah, we can obviously will continue the other modalities. Intervention, if we feel that that's going to help with the pain, keep the patient comfortable, I think we can go ahead with that as well. It just depends case by case which patient,
But sir, it means there is no time limit at which we
No.
should think we should start intervention.
No,
Or
there is no.
there is no lifespan specific that if we think patient will live for 1 year, then we should go for intervention.
Yes,
Or if patient will probably have 6 months, then we should not go for intervention. Is there anything like that?
No, I don't believe there is anything like that as long as we are getting patients some relief. So,
Okay, sir. Thank you.
thank you.
Yeah, Rajlakshmi, we can start the case presentation.
Dr. Prakar, over to you.
Yeah, hi. So this is a patient with chronic pain, a non-cancer pain. Can we have? So she's a 50-year-old female who is having a post-surgical spine syndrome or failed back syndrome, as we called earlier. Now she has presented to the neurosurgeon with pain in both legs, and she is having more pain on the right side than on the left side. This kind of pain has started after spine surgery 1 year back, and the severity of this pain has increased and decreased over the last 1 year. But for the past 3 days, it has become very, very severe. The pain is burning in character with pins and needles feeling. She's having a lot of numbing in the legs. It radiates from lower back to the foot, and even previously non-painful activities like bathing, wearing shoes have also become painful. So she's not able to take bath, not able to wear clothes also properly. The pain is persistent throughout the day, but increases in severity toward the evening. Earlier it was relieved with analgesics, but now not relieved with pain medications also. And the pain is very severe in intensities. VAS is almost 8 and 9. Past history, she was having back pain for the past 2 to 3 years with occasional exacerbations. She underwent the spine surgery, lumbar laminectomy and fixation 1 year back. Immediately after surgery, she developed tingling, numbness of her right lower limb along with right foot drop. So she had some neurological weakness after the surgery. This was treated with IV followed by oral steroids along with physiotherapy for the next 3 to 4 months. With this treatment, her foot drop improved, but the pain has persisted and increased in intensity over the last 1 year. On examination, there is no redness or swelling in either leg. The scar of previous surgery over lower back is seen. There is tenderness over lower back, a diffuse tenderness over lower back is present. There is no sensory loss, but she is very apprehensive to touch sensation. The power is normal in all limbs, EHL right 4/5 and left 5/5. Reflexes are normal. SLR, flare, and Faber tests are negative. And for the last 1 year, she has been on multiple medications. The neurosurgeon did an MRI recently, which shows L4, L5, S1 implants, widespread PIVD, adhesions, and fibrosis with decreased canal diameters in the lower back. These are the medications she is taking. Tab duloxetine 20 milligram twice a day, tab pregabalin 150 twice a day, Ultracept 1 tablet thrice a day for the last 1 year. Thyroxine 75 mics once a day, and Telma and Nexito tablets. Now, she's a single mother of a 16-year-old daughter. She's working, and her husband expired during COVID. Her work is affected due to severe pain and tingling, and she has taken multiple leave from work because of this severe pain. She is depressed and unable to sleep. She thinks that the pain will last her lifetime. She is afraid that the doctor has done something wrong with her. That is why the pain is continuing. And the neurosurgeons are also getting irritated with her pain. And she feels that there is no cure for her pain. She is afraid to undergo any further treatment or intervention, fearing worsening of her symptoms. Her logic is that at least she is able to walk now. If the symptoms increase again, then she might not be able to take care of her daughter again. So the main concerns are that she's having a post-spine surgery, severe neuropathic pain, which is affecting her daily activities and work. She's on multiple medications and antidepressants. And the surgeon's logic is that there's nothing correctable on MRI. So they are doubting how much pain she's actually having. That is why they have referred to the pain physician. So in summary, she's a 50-year-old professional having severe burning pain with tingling and numbness in both her legs after spine surgery. She's on multiple medications. The pain is affecting her daily life and also work. She is worried that she is unable to work. Her daughter will suffer more. So the discussion points main are management of post-spine surgical pain, how to investigate, how to manage, what interventions to do, management of severe neuropathic pain, and can we have predicted and preemptively treated her, because she after surgery she developed this foot drop and tingling numbness sensation. Can we have treated her at that time only to prevent this severe escalation of pain which she is having?
Thank you so much, Dr. Prakash. What a relevant patient story for today's discussion. And this is really, when thinking about from the patient's perspective, this is a really hard time because she has underwent surgery and again going through pain, not believed by many people. And we don't know what can be offered. Thank you so much for bringing this up for today's discussion. I understand there are not many participants using interventional pain management in their practice other than 2 or 3. So probably I would like to ask the faculty member regarding their, how would they manage this case if it was their patient. I understand that Dr. Sanjay's and Dr. Mayank's practice will be very different because you are both in a very different setting. So it will be interesting to know from both of you.
Okay. Dr. Mayank, you want to go first?
You can go, sir. You can please address the question.
Okay. All right. Sorry, my mic. So this is a very interesting case of a post-laminectomy syndrome that we have here. This is a 50-year-old lady who had back surgery, possibly a laminectomy, about a year ago, and she has not recovered much after that. And as you have stated, the outcome is not very good with back surgery, especially post laminectomy, and she does have some radicular pain. First of all, I would like to ask her, from her history, we'll get whether it is confirmed to which dermatome, and if it is a dermatomal pattern of pain, I think what pain is more on one side than the other. And of course, her medication wise, she's on NSAIDs, pregabalin, she's on tramadol, she's on SSRI. So medication wise, I think she's okay. Probably it will be a good idea to try some interventional, like a transpyramidal epidural steroid injection, or we go in for caudal epidural. I think it will not be a good idea to go in straight to into the lumbar area because of the scar and everything, and we don't have any epidural space after surgery. And what happens when they have surgery? There is so much scar tissue that it also entangles the nerve roots and the nerve fibers, and that itself can be a cause of pain. And in medication, I'd maybe go up a little bit on the pregabalin, and otherwise, I think she's fine with that. And try an intervention and see she's come to our clinic and how she responds to that. And now the thing is, she has there is some acuteness to her symptoms. I mean, the pain has been there for several months, almost a year after surgery. She really didn't recover, and she has also been getting some therapy, and she's a professional, so she probably is a compliant patient too. So I don't know how long back her MRI was performed. Maybe something new, get something from the history. Well, was there any event that exacerbate her pain? Did she fall or something, or anything happen? Because I'm a little concerned about the acuteness of her. I think past 3 days pain is very severe, or maybe it's just a progression of her symptoms, and that's what she's telling us. And
Yep. So this time, actually her daughter's 10th examination was there. She was worried about the secondary examination for the daughter, and that has precipitated the pain. That is why the surgeons think that it is more psychological related than actual pain.
Oh, okay. Actually, pain is pain. We cannot. We have to believe what the patient is saying. So, if it's okay, I don't know how it would be. How long her MRI was. I would also get a new MRI for her, and also do an electrodiagnostic test like EMG nerve conduction studies to see the physiology of her nerve, if there's any actual nerve damage or not, and we can go from there. But right away, I think I don't know how you all proceeded, but I would start with a transforaminal epidural steroid injection, depending if it has a dermal, very specific segmental or dermatomal pattern. We'll go to the specific nerve roots, or even a caudal, because it's bilateral. We can do a caudal epidural steroid injection. Go from there, and probably the last in the line would be a spinal cord stimulator. If she does get some relief, but it wears off after some time, and then she comes back and with the therapy and everything, ultimately we can, because she's not going back for surgery, so nobody's going to operate on her again. And a spinal cord stimulator might be something further down the line, depending on how she responds to the treatment. That will be my take on it. So.
Thank you, Dr. Sanjay. Mayank, would like to hear from you.
Yeah, thank you. So I fully agree what Dr. Sanjay said. Sorry, Dr. Prakar, I missed the earlier part of the presentation. May I ask a few questions? That is it the predominantly back pain or the predominantly leg pain that she has?
No, now she's having predominantly leg pain, and more than pain, she's having a burning sensation during the in the legs. She's not able to wear shoes or clothes, not even able to take bath. When the water goes down on the legs, she's having very burning pain in the legs and all over the legs. From the back, it reaches to the foot.
Okay. And so you mean to say it's a non-dermatomal distribution of pain? Is that so?
Yes.
Non. And apart from this pain, does she has any pseudomotor and vasomotor changes in the leg? I mean to
No,
say
no, no, no,
changes in
no.
the color, or the patient sees that she gets edema in the leg. Because I'm thinking in terms of CRPS, or a sympathetically mediated pain post-laminectomy, which has developed post-laminectomy. Are there any pseudomotor, vasomotor changes which patient has?
No, sir. No edema, no change in the temperature, no redness,
Sure, sure.
swelling.
Does she has neurogenic claudication? I mean,
She's she's unable to walk a lot and not
okay.
able to give. Yeah.
So from history, it seems like due to extensive epidural fibrosis, her nerve roots are getting compressed, and that's why she is now having this pain, all burning and tingling pain in the legs. So apart from the epidurals, I don't earlier I have done, but since few months I have not done what it's a RAX adhesiolysis for patients with in which I think it's a lumbar canal stenosis due to epidural fibrosis. So you put in it's the just like we put an epidural, we go through the caudal space. Other than we don't use a Tuhi needle, we use a RX Coude needle, and there is a special catheter which is the RAX catheter, which you can manipulate within the epidural space. So you can do adhesiolysis. You can go and have a read about it. Have you ever heard about it, Dr. Prakar, adhesiolysis?
Yes, sir. Yes, I'm done.
Yeah. So apart from caudal epidurals, I can think of RAX adhesiolysis. Yeah. Other than that, yes, I can't think of anything else. Yeah. What's your take on that, Dr. Sanjay? May I ask?
Yeah, yeah, thank you. Actually, I would not start with the adhesiolysis. I would just start with the spray straight away. You bring a good point, Dr. Mayank, that it could be a sympathetically mediated pain, because I don't see a clearly dermatomal picture here. So maybe just a block to start with, like a transforaminal, and see, or maybe not. Sorry, I take that back. Maybe just straight away caudal epidural with the catheter, with the RAX catheter, or anything, just straight up and see if there is relief or not. And then if she gets relief, well and good. I mean, start with the less invasive stuff and then keep on progressing more and more invasive things. So
yes. So this was after, if the patient does not get relief with the caudal, or she gets little pain relief with the caudal, but the pain comes pain comes early after that. So I was talking in terms of that, what next other than caudal. So yeah, adhesiolysis. And if we because I have seen few patients who have that sympathetically mediated pain as one of the causes of post-laminectomy pain. See, post-laminectomy pain, if you see, it's not one disorder, it's a multiple disorders. You have to see that what is the pain generator. Is it the same level which the patient used to have the pain? Is it the same pain which the patient used to have and the pathology has developed at this level, or is it due to the epidural fibrosis, or because the patient has undergone laminectomy, there is an excess stress on the above and below facet joint, which is patient is having facetogenic pain. But as you said, patient is having predominantly leg pain, and in the feet, I don't think facetogenic pain as the common etiology of pain. So what looks like is either she has a sympathetically mediated pain, or it is due to the epidural fibrosis patient has pain. So yeah.
Thank you, Dr. Mike. Actually, do you do a lot of these epidural adenolysis at your clinic?
So previously I used to do. The problem is that we don't get RX Coude needle and the RAX catheter because of some issues with the import of these devices from the outside. Initially, one of the MRs, he somehow got catch hold of some of the catheters and the needles. So at that time we used to do, but now no. And we have tried with the normal epidural catheters and the needles. We all know that they are hard to manipulate. We cannot manipulate them.
Yeah, they're very so flexible. So yeah, that's true.
So
okay.
Yeah, no, I haven't done that. So only thing is that if I think that the pathology is up and is not amenable to caudal, we go for an interlaminar And if it involves bilateral and has multiple dermatomes, then we go for an interlaminar epidural. But my first preference is if it's a single dermatome, I go for a transforaminal. If it's multiple dermatomes, bilateral, and the lower I mean to say the lower nerve roots, I go for an caudal epidural.
Okay, thank you. Over here, it is becoming less and less popular for some reason. Before it was very popular, and now less and less people are doing it for some reason. I think here in the US, the surgeons are very aggressive. They will just operate on anybody, you know. So,
That's true for India too, sir.
yeah.
Thank you so much, Dr. Prakar. If do you have any other questions? How to go ahead with this patient? Or
Yes, ma'am. So actually, what I did for her, I gave her a caudal epidural steroid injection, and after that injection, we were able to taper most of her medications, and she had adequate pain relief for the next 4 months. After 4 months, she has come back again, and she is saying that the pain is coming back, the tingling numbness, without medication, and she is now able to wear her shoes and all. She's able to go to work and all. So, but she doesn't want to go for any intervention now because she's afraid that if the condition comes back, then her work will affect again. And she is not very keen on starting any medications again because they were making her sleepy.
I think so. 4 months of pain relief, lowering down of medications, improvement in activities of daily living is an excellent pain relief which we can expect from a caudal epidural. So well done, well done.
Yeah, I would agree to that. Thanks.
Yeah, but the pain is coming back again, and so I'm a bit.
I think so. She should
Well,
do. She should have another setting of caudal epidural. It's an example of an excellent pain relief with caudal epidural. She had, yeah.
yeah, I think, but the patient is denying any intervention and medication, right, Dr. Prakar? I think, yeah, that's where we may need to convince or counsel the patient regarding the need for, I mean, some treatment has to happen, otherwise she will end up in having more and more pain. And as Mayank mentioned in his presentation, there is more chance of sensitization and then related complicated pain on a later date. So there won't be a, I mean, without intervention, without medications, I guess it would be difficult for her to manage probably.
Dr. Mayank, one question, please. If I give an epidural to his needle and I inject a lot of saline for hydrolysis, will that work for bettering the fibrosis?
One must always keep in mind that there is already less of epidural, there is already less of space for the nerve roots and they're already compressed, because of which the patient is having pain. If you give a lot of saline within the epidural space where there is hardly any space, the chances, I see the chances of side effects. I mean to say the probability of side effects being more. I've never tried that. Yeah, Dr. Sanjay, what's your take on that?
No, I would not do that because it might make the symptoms worse if you.
Yes, that's what
There's a lot of scar tissue in there. There's a lot of some spinal stenosis. We're going to aggravate the symptoms. So I would stay away from that.
Yeah, thank you.
Thank you so much, everyone. I understand most of us don't have access to interventions, but this should be a, I guess this would have given a new area where we know that what interventions are available, or when can we actually think about intervention. Even if you don't have that in your own setting, you can always refer to an intervention pain management place. So we should know when to refer and what all modalities are available. Unless you know, you will never explore these possibilities. We just keep changing the medications, and that's why the importance of this today's session come in. Thank you so much, all the participants, for your listening and being here for with us for the session. Thank you so much, Dr. Sanjay and Mike, for being with us, sharing your knowledge and experience as well in doing these interventions. Thank you so much, Dr. Prakar, for bringing in good case presentation in terms of learning, because this was very well suited for today's session. Thank you so much, everyone.
Thank you.
Thank you. Thank you.